I'll be speaking on interlaminar endoscopy for recurrent lumbar disc prolapse. So I'll be discussing under these headings. As per WFNS spine committee recommendation, recurrent lumbar disc herniation is a new disc herniation at the index level, same side after initial surgery. As per AO, it can be on opposite side also. Incidence is reported in the literature is 5 to 18%. Patient can be conservatively managed without any neurological deficits, but revision surgery gives good results and significant improvement after compared with the baseline. Reoperation rate is 5 to 19%. The multiple risk factors can predict the recurrence rate, including smoking, younger age, male, gender, obesity, diabetes, disc degeneration, and presence of lumbosacral translation vertebrae. The level of surgery and the amount of disc material removed has no correlation with the rate of recurrence. So it's a retrospective analysis in 321 patients by Jhala, which says that patient factors like male sex, younger age, higher BMI, smoking, and occupational history of lift weighting, trauma as higher incidence of recurrence. And the radiological factors like transligamentous extrusion, increased disc height index, increased sagittal range of motion, facetal tropism, low facetal tropism, and facetal orientation higher level can cause a recurrence. The meta-analysis by Lin Jiang reported that younger age, higher BMI, and sagittal range of motion, higher sagittal range of motion, diabetes, smoking, and more modic changes correlate with the postoperative recurrence. Coming to management, patient with neurological deficit or with the symptoms which are refractory to conservative management, surgery is the option. We have two options like only discectomy and discectomy plus fusion. In the absence of segmental instability and spinal deformity and no backache, so only discectomy suffice. And we have options like open, microscopy, endoscopy. The only discectomy has an advantage of shorter operative time, shorter hospital stay, quicker recovery, low finance, and no implant-related complications. Then why endoscopy and recurrence? We have options of open, microscopy, and endoscopy. Because in revision surgeries, there is a difficult plane of dissection between the neural and scar tissue. And in open surgeries, we have wider exposure, which can lead to instability. Additional problems like bleeding, dural tear, nerve injury can be occurs. So most of the studies showed that adhesive scar tissue and postoperative instability encountered in open surgeries can be overcome by endoscopic methods. It's a study by Rutan et al. They showed that recurrent lumbar disc can be sufficiently removed using full endoscopic technique, and it is a safe and effective alternative for microsurgical procedures. And the clinical results are equal to microsurgical techniques with a lesser trauma. Similar results by Kim et al., which show that endoscopy is an effective alternative with a comparable clinical outcome and less complications. In open surgeries, after initial surgery, the revision surgery has lesser clinical outcome and lesser patient satisfactions. The good results, good to excellent success rate after 2 years follow-up was showed by Hoogland et al., who followed 262 recurrent lumbar disc herniation by endoscopic methods. So endoscopy, we have two options. One is transforaminal and interlaminar approach. While the transforaminal, we have a virgin surgical field and no scar tissue, but the limitations are lesser mobility, access-related issues, and sometimes inadequate removal of the herniated disc. So interlaminar will answer most of the queries. It's more versatile and it's more mobility. So a brief technical note of interlaminar approach for recurrence. As in all procedures, preoperative planning is must, and the entry point should be previously predetermined. You should choose unviolated bony landmarks. So after skin incision and facial incision, the dilator should be docked on either superior edge or a lateral edge of the interlaminar window to avoid direct penetration or plunging into the epidural space. Once the dilator is passed, the working sheath is passed over the dilator and the scope negotiated. After that, the soft tissue is removed to define the bony landmarks and lamina. So most of the cases, and post-operative cases, the laminar window is sufficient to remove the disc. In some cases, it might need drilling. For a beginner, drilling more bone and going into the virgin area will be the better option. This is after docking. We are just defining the bony landmarks. After the defining bony landmarks, you should orient anatomy to yourself and proceed. This after defining bony landmarks, the curate is used to define, to separate scar tissue from the bony landmarks. Once the soft tissue and bone were drilled adequately, the ligamentum flammum is seen and it is carefully entered into the epidural space. And you should define the lateral margin of traversing route before proceeding for the discectomy. After defining the lateral margin of traversing route, any scar tissue which is adherent to the epidural, which is adherent to the thecal sac or traversing route is carefully removed. You should not pull it. You can just cut it or try to separate carefully. So once lateral margin of the traversing route is visualized, which the lateral root and thecal sac is retracted with a sheath to see the annular defect. Sometimes you can feel with a dissector. So the herniated disc, if the herniated disc material is too large, only the graspable part is removed first to relieve the tension and neural structures and create more space. So decompression is confirmed with, by visualizing the thecal sac and lateral margin of the root. So in recurrence, the size of incision also matters because there will be a wound-related complication, especially in recurrent cases. So endoscopic interlaminar approaches has less incidence of dural tears when compared to the open surgeries. It was reported, Shin et al. In 2 patients in 41, and Rutan reported 1 in 50, and Kim reported none in his 10 cases. So the irrigation in endoscopic procedures maybe gives a better visualization, and hydrodissection can help. This may be the lower incidence. This may be the reason for lower incidence of dural injury. So you should maintain a balance between aggressive dissection, that is separating the scar tissue from the neural structure, and avoiding dural injuries. So it is better to retract them as a unit rather than trying to separate and injuring. So scar typically doesn't cause symptoms, it just limits the space. It's the herniated disc which causes a compression. The removal of only disc material can relieve the symptoms. If you chase scar, there is no guarantee that readhesions won't occur after the multiple surgeries. Retaining some scar will help protect the neural structures during the discectomy. So it is better don't chase the scar, be wise. For a beginner, it is always wise to seek guidance from your mentor or help from them before attempting on your own. Thank you.